Today, we are privileged to have Rachel Maguire with us to provide highlights from the Institute for the Future's research into how the changing nature of work is influencing the health of individuals, families, and communities over the coming decades. IFTF is on the cutting edge of strategic foresight research and application across a wide range of audiences, and we're very fortunate to have Rachel join us today. Since 2006, Rachel has studied the intersecting and interacting forces shaping the future of how we learn, work, play, and take care of one another. While her research efforts stem from her deep understanding of healthcare policy, her foresight work situates the future of health and healthcare within the context of external forces that are shaping the next decade. Rachel combines linear trends with larger technological, demographic, and economic influences to better anticipate directional change in the future of self-care and clinical care. She is also skilled in expert aggregation techniques, routinely facilitating workshops and panels of people with diverse backgrounds to discuss and debate future scenarios. To gather firsthand views of changing practices and beliefs, Rachel has designed and conducted ethnographic research in both the United States and in Latin America. Rachel has shared her perspective on the future of health and healthcare in a variety of outlets. Today, she'll offer future perspective on how work arrangements such as gig, contingent, and shift work are combining with economic policies and technological forces to shape the future conditions of work. And now it is my real pleasure to introduce Rachel Maguire.
Thank you, Sarah, and hello to everyone. Thank you so much for the invitation to participate in Foresight Friday at NIOSH. If I understand correctly, I think I am the final speaker of this year's series, and it's a real honor to be here with you all today. I'm looking forward to the discussion that I hope the Foresight content I will share will spark among us, and if this medium allows for that. Now, for those of you who are less familiar with the organization where I work, Institute for the Future is an independent, not-for-profit research and teaching organization that's based in Palo Alto, California. And for the last almost 55 years, we've been studying the future and teaching the tools, techniques, and mindsets of foresight to help individuals and organizations of all kinds think more systematically and perhaps a bit more creatively about long-term futures. Our objective is to socialize foresight content and the tools we use as broadly as possible, with the hope of turning ideas about the future into actions in the present. Now, this is not the first time someone from Institute for the Future joined you all in Foresight Fridays. My colleague Lynn Jeffrey participated back in March of 2021. And her talk focused on disseminating futures content broadly and effectively. Now, in IFTF's approach to strategic foresight, Lynn's talk would really be situated in the action phase of our foresight to insight to action cycle. Some of you may be familiar with IFTF's FIA cycle. This is how we organize a lot of our strategic foresight. Our thinking is that the process works best when you do some preparation, which I'll get to in a second. Then you do your foresight research. You use that insight phase to think through the implications, positive, negative, or otherwise, that might emerge from the research or from the foresight that you've developed. And only after you've done that deep insight work do you move toward action. And if the actions are bold enough or transformative enough, oftentimes it shifts the future, and therefore it's a cycle. You start the work again. So when Lynn was sharing observations, approaches, and best practices that organizations use to apply foresight content to inform those strategic actions, she was really highlighting some of the tools and techniques that we use in that action cycle. My talk today will fall more in the foresight phase of the cycle, because I'm going to provide a high-level overview of the foresight research that we at the Health Futures Lab at IFTF are conducting to better understand the impact that the future of work specifically care work, will have on the health and well-being of individuals, so the workers themselves, as well as the health and well-being of their families and maybe even their communities. But before I dive into the foresight content, I'll first employ a practice that would fall under the prepare phase of this cycle. It's what we call looking back to look forward. Now, the common tenet is that you are to look back at least twice as far as you hope to look forward, but I'm only going to take us back 10 years, back to 2011. Now, some of you may remember that there was a very popular, if not dominant, narrative about the future of work in the early 2010s. And the narrative was that technologies were advancing at such a fast clip that soon intelligent systems would be able to do most of the jobs that humans were currently doing. Eric Brynjolfsson and Andrew McAfee's book, Race Against the Machine, was one highly influential source for this view on technology, but it certainly wasn't the only one. The view that technologies would soon be so sophisticated as to replicate human behavior and decision-making was rather commonplace 10 years ago, and it set off a steady stream of articles, books, and convenings on what would be left for humans to do once technology had replaced us in the workplace. Now, fast forward 10 years, and while robots and intelligent systems are continuing to enter the workforce, we're still waiting for this complete robot takeover. And now the more dominant narrative about the role of these new technologies is following a pattern that's more consistent with how most technological advancements have integrated into our lives in the past. Robots, AI, cloud computing, and the suite of emerging technologies that are entering the workspace today are not necessarily replacing us, but they may be changing the nature of how we work. Now, it's not easy to try and capture all the large issues that are informing the conversation about the future of work today, but in the spirit of some level setting, I'll try to hit at least a number of the big ones. First, the steady march of automation continues, and this is impacting different sectors at different rates and at varying levels of intensity. Algorithmically run organizations have ushered in a whole new way of working and possibly new worker classifications. And wage disparities are in most conversations about the future of work, and a smaller but growing number of researchers are looking not just at income inequality, but also at wealth inequality. And finally, there are these large, slow-moving structural changes that are informing the present as well as the future of work, changes that I imagine many of you are tracking closely. David Weil at Brandeis has described the corporate practices of offshoring, outsourcing, and the use of staffing agencies as the fissuring of work. And he offers that it's this fissuring of work that has contributed to contingent employment, weakening bargaining leverage for workers, and a greater risk for exposure. So the future of work has been and continues to be a robust and dynamic topic. But our question as health futurists is the following. If the ways in how we work and where we work, and maybe even why we work, are so fundamentally changing over the next decade, and if we agree that work plays an important role in our overall health and well-being, then why aren't more people talking about the future of health in these conversations about the future of work? Now, please don't misunderstand me. I know there are some people talking about this changing dynamic between work and health, and many of the people who are doing this are connected to your organization. They're connected to NIOSH. But we at IFTF's Health Futures Lab are also seeing all this attention on the future of work as a golden opportunity to ask new questions when it comes to the intersection of health and work. There is excellent research out there on the health risks associated with different types of jobs, but it seems that there is less research about what kind of work produces good health. Research seems to be able to demonstrate that unemployment is bad for your health, but the findings are less conclusive when it comes to the impact that employment has on our health. Whether or not work contributes to one's health positively and negatively seems to depend on the nature of work. So if the nature of work is changing, then maybe it's time to revisit what we understand to be the attributes and characteristics that make some work beneficial for the health of individual workers, their families, and their communities. In other words, what will health-affirming work look like in the 2030s? Now, spoiler alert, this presentation does not include firm answers to that question. Instead, what I'll do here is offer some of our observations in the hope that it will motivate some of you to apply your foresight capabilities to this intersection of work and health to help build out the research and knowledge base so we can have more decisive answers about what health-affirming work in the 2030s could look like. I'm going to focus our observations about health-affirming work on the healthcare sector itself, because looking out 10 years, it will have an outsized role in the work composition of the next decade. And so, on to the first observation. The first area of exploration is around economic security. Now, there's nothing new about the observation that economic stability or security and health are correlated, that generally speaking, economic security is good for your health. And we know from Comprehensive Bureau and Labor Statistics and Department of Commerce data that the demand for home health and personal care aids will be among the highest of all occupations over the next decade or so, largely due to the anticipated demographic changes and the corresponding health needs of an older population. But just to give us all some sense, BLS is estimating that there will be over 700,000 openings each year in these occupations for the next decade. And we also know that without any correction, most of these jobs will not pay a living wage in most parts of the country. According to the most recent BLS data, the salary for these jobs ends up being just over $29,400 per year if you work full-time. And most of these jobs come with no benefits, no retirement, and no time off. So another way of thinking about not paying a living wage is that these jobs pay a poverty wage. Poverty wage is defined as an hourly wage that would leave a full-time, full-year worker below the federal poverty guideline for their family size if they're the sole earner in the family. And the point here is when it comes to our individual family health and well-being, low wages, minimum wages, poverty wages, whatever you want to call them, could be viewed as occupational hazards. Now, some of you may be familiar with the sociologist Matthew Desmond from Princeton University. In February of 2019, he wrote a long piece on the justification for raising the minimum wage, and many of his arguments centered on health. And building off the work of Professor Lee at UC Davis and his colleagues, Professor Desmond's arguing that we should think about poverty wages as dangerous to workers' health, just as dangerous as we think harmful chemicals are. He wrote, "There's little difference between low wages and workers being exposed to asbestos, harmful chemicals, or cruel labor conditions, because poverty compromises the well-being of workers and their children, just like chemical toxins and the poor treatment of workers do." Now, there are novel innovations that may protect workers from this health risk, the health risk associated with low wages. Home healthcare worker cooperatives are sprouting up across the US and Canada to create more quality jobs for care workers. These cooperatives are owned by the caregivers, and while many would suggest they have a long way to go before they can provide family-sustaining wages, they are designed to provide better pay and more economic security for the worker owners. it would be interesting to know more about the health and well-being of worker owners and if it's affected by this new way of working. Now, you are all the professionals when it comes to occupational safety, so I'll leave this idea that poverty wages should be considered as an occupational health risk as a provocation for you all to discuss among yourself. But returning to the larger exploration, I'll offer that if we agree that economic security is required for health-affirming work, then the millions of home health and personal care aid jobs that we anticipate adding to our labor force will not enhance or even maintain the health of those who do that work. In fact, the hard truth here is that they may very well detract from individual health and well-being. Care work, then, if we carry out the logic, could or perhaps should be seen as a health risk to individuals. Now I'll move to our second observation, which has drawn our attention to the role work plays in our social health. And I won't use more than 30 seconds here to remind us all of the massive shift that occurred during the pandemic, in which millions of face-to-face medical appointments converted to telehealth appointments. But just one data point on this. In a 6-week period during the spring of 2020, telehealth usage for Medicare recipients increased 11,718%. Now, I know some of you numbers people may not be impressed with that percentage, since prior to the pandemic, there was only a small number of Medicare beneficiaries that were using telehealth services. But I think the important takeaway is that the shift from face-to-face to digitally enabled care services was not a linear transition. Like everything else in the spring of 2020, it was a dramatic change in how healthcare services were procured. And as physical clinical spaces reopen, many healthcare systems are preparing for more of their service delivery to remain in people's homes. Many healthcare service systems obtained waivers during the pandemic to participate in Medicare's acute hospital at home. Even as pandemic-related reasons for care being delivered at home are dissipating, policy changes like hospital at home and the corresponding financial and tech investments suggest that care services will continue to move into the community. Providing acute hospital services is just one example of many US health systems' efforts to meet the goals of patient-centered care by providing services in patients' homes and in the community. And of course, health systems are hardly alone when it comes to healthcare services moving to the home. From health coaches to teletherapists, startups, health insurance companies, tech companies, even primary care, everybody's recruiting a workforce that will support this new geography of healthcare. And one source that we watch at IFTF to see where the future is going are the job posting websites. And if you look now, you'll see so many jobs that assume that people will be in their home needing health coaching, health monitoring, and all sorts of other supports. Now, more research is sorely needed to track and understand the impact that a distributed care model may have on the well-being of the traveling healthcare workforce. We know from gig work that rating and tracking can produce new stressors on workers, but as gig work intersects with the healthcare sector that is decentralizing, it's crucial that we look at the social health of healthcare workers as these new models of care roll out. Care, particularly hospital care, has historically been a highly centralized, in-person kind of work environment. If we are imagining a future in which these jobs are now conducted virtually or in locations dispersed across a geographic area, it'll be critical that we understand the impact that this new style of working will have on individuals' workers' sense of community and belonging. Stated differently, to what degree has work that has been centralized in a health facility served as a protectant against loneliness? And what happens as that work decentralizes. And this leads me to the final area of inquiry that I wanted to share with you all today. This one is around the role health-affirming work will play in healing from past harms. I will not spend more than half a minute making the case that healthcare workers are burned out after the last 3 years. Survey after survey shows that they are not just exhausted and burned out by work, but they are anxious, and many, upwards of a fifth of them, are even angry. So even before we grapple with the health impacts propelled by these fundamental changes to how we work, how do we heal a workforce that has been emotionally harmed by their work? Now, 2 observations that we and others have made about this current crisis of burnout in healthcare. First, clinician burnout was a problem long before COVID. In 2017, Stanford Medicine made news when they were the first academic medical center to hire a chief physician wellness officer. And as you can see from the news headline, burnout was already seen as a national epidemic. Dr. Shanafelt, who they hired, had been studying physician burnout at Mayo for a long time before he switched to Stanford. And 2 years later, the National Academy of Medicine published its own report on how to address the alarmingly high rates of clinicians who were experiencing substantial symptoms of burnout. So burnout was already a serious strategic issue for healthcare prior to COVID, but it bears worth mentioning that, like so many other things, it only got worse during the pandemic. A recent study out of Mayo reported that only 1/3 of physicians are satisfied with their work-life balance. The findings of this report on burnout levels and job dissatisfaction are some of the largest increases in emotional exhaustion that seasoned researchers in this area have ever seen. And the second observation is that despite the call for systems approach to address professional burnout, most of the interventions and the stopgap measures are targeting individuals. Health systems have made changes to schedules and workloads, as well as made resources available for coaching and stress management in the hopes that employees will take advantage of these new resources. Some systems are even experimenting with novel interventions, such as these recharge rooms at Mount Sinai Health Systems. These recharge rooms are designed to address trauma, anxiety, and stress, and improve cognitive performance through music, scent, lighting, and sound. But from stress management to coaching to even these recharge rooms, they all continue to place the burden of recuperation and restoration directly on the individuals, when in fact, health-affirming work may require systematic change. Health-affirming work may mean that we stop fixing the workers and we start fixing the work. And one area that is in desperate need for fixing is the racism that still exists in the healthcare system. Now, there's equity dashboards today that are interesting tools to watch because some systems are using them to identify racism in real time and the and is critical, using them to address the harms in real time as quickly as possible. At UCLA Health, they are tracking both the organization's performance in equity as well as their performance in health equity. So if you think about the next 10 years and you think about care work, for us, what we've recognized is that health-affirming work must produce economic security, it must enable social connectivity, and it must include restorative healing that's at the systems level, not just at the individual level. So those were the 3 ideas I wanted to bring into your world today, and I'm looking forward to hearing from you. And so that's why I'm ending with this question of what is, in your mind, the characteristics and the attributes that we should think about when we're thinking about health-affirming work now and in the future. So I'll leave it there and hope that the Q&A will include not just the cues, but also some thoughts you have on this question.